I see the captions testing. Thank you to the captioner. Looks like we're good to go.
And it's that one for you. That's your mic. It does light up red. And that's
Okay.
how you know that
That's
it's
how
on,
I
then
know
hit
it's-
it, then turn
okay.
it off.
Well, good morning. It's 9:30. I would like to go and welcome everyone to call the Health and Hospital Committee to order at this time. I am County Supervisor Otto Lee, Chair of this committee, and along with my Vice Chair, Margaret Abekoga, with both supervisors present, we have a quorum. And then moving to item number 2, which is the public comment. Item reserved for members of the public to address this committee on any item that is not on today's agenda. Any public would like to address this committee on these non-agendized items should speak at this time. Morning.
Good morning. I have no
any speaker?
request to speak on item 2.
2. Okay, all right. Go and close and move on to item number 3, which is the approval of the consent calendar and changes to the committee's agenda. I would actually propose to add item number 8, which is receiving report from Santa Clara Valley Healthcare relating to workplace safety efforts to consent, if that's okay to my vice chair.
Yes.
Okay, good.
Right. I'm happy to make a motion to approve the consent calendar with item 8 added to it.
Yes, and I will second that. And I requested a report earlier, and I'm glad to see this report on item 8 has been progressing well throughout the our Santa Clara Valley Health System, and don't have really any further questions. All right, if no further changes and questions, let's see. Any public would like to speak about the agenda?
May I briefly request you get closer to your microphone?
Oh, sure, my bad.
Thank you. I also have no request to speak on item 3.
Okay, all right, we'll go ahead and take the vote.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
I as well.
Thank you.
Okay, moving to item number 4, which is recommendations relating to the medical staff and allied health professionals at Santa Clara Valley Medical Center, O'Connor Hospital, St. Louis Regional Hospital, and Regional Medical Center. And let's see, who do we have today? Oh, here you are. Hi, Dr. Salmon. Not recognizing you up on the dais now. Welcome. Yes, and do you have anything to present this morning?
Good morning, Supervisor Lee. I believe you have the report before you. I'm here to answer any questions. Otherwise, kindly request your approval of our credentialing report.
Great, thank you very much, Dr. Salmon. Yes, Vice Chair, is your lights on?
Oh, I'm sorry.
You have a motion?
Yes, I will make a motion to accept the report.
Great, and I will go and second that. Let's see if we have any public like to speak on this item.
I have no request to speak on item 4.
Okay, let's go ahead and take the vote.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
I as well.
Thank you.
Thank you. Okay, item number 5 is to consider recommendations relating to the federal and state health policy and budget landscape. And this morning, we have, I believe, Bert McGowan from the McGowan Group and Amy Carter from Clara Valley Health as well. Welcome, good morning. Oh, the wife, no, we'll try again.
Oh, wrong microphone. Good morning. Happy to be with you.
There we
this
go, we
morning.
can hear you. Thank you, good
Now
morning.
you can hear me. All right, let me start with my report updating you on what's happening at the federal level. As we all know, Congress is currently engaged in a very intense negotiation over the final form of the reconciliation bill, which we've all been watching closely and which will include major cuts in the Medicaid program. Let me start with an overview as to where the bill currently stands. On May 22nd, the House passed its version of budget reconciliation by a vote of 215 to 214, a one-vote margin, straight party line. That bill included roughly $800 billion in Medicaid cuts over a 10-year period. It included, among many provisions, a 10% reduction in the enhanced 90% match that we receive for our Affordable Care Act expansion population. If the state provides health coverage or financial assistance to undocumented individuals. It's a penalty, in effect, for covering the undocumented, and that's an issue that would have a major negative impact on California, one of many issues in the House version. So with no votes to spare, Speaker Johnson urged the Senate in taking up reconciliation to not make major changes because it would jeopardize, he said, the chances of this carefully balanced bill passing in the House with Senate amendments. The Senate, of course, ignored this advice and is in the process of making major changes to the bill. They're doing it in a closed-door, committee-by-committee process. There are not open hearings. Each committee is developing proposals one by one and releasing them to the public for their review. The Senate Finance Committee, which has responsibility for Medicaid, released its version on June 16th. And the changes that they made on Medicaid made the cuts much worse and provoked major pushback from various Republican senators. While no CBO score has been attached to the Senate Finance version yet, there's a general view that the cuts are about $200 billion more than the House version. So we go from $800 billion to roughly $1 trillion over 10 years in cuts. Another major theme, in what the Senate Finance Committee did, is to separate out the states into two categories: the expansion states that chose to expand Medicaid under the Affordable Care Act to childless adults and to a larger population, and the non-expansion states. For the expansion states, about 40 states have expanded. The cuts are worse. There's a penalty for expansion. For the 10 states that did not expand Medicaid, they're rewarded for that in the Senate proposal by having less severe cuts. That's the philosophy or ideology of the Senate Finance Committee. The biggest controversies in the Senate proposal there are many controversies, involve the financing provisions, and there are two that I want to highlight just briefly. The first is the provider tax, which operates in 40 states, including California. The provider tax is a mechanism by which the state taxes healthcare providers and uses those funds to put up the non-federal share of the match for Medicaid. The formula and mechanism for doing a provider tax has been controversial for a long time for lots of reasons, but the House recognized that simply terminating this provider tax would destabilize healthcare systems across the country, and what they chose to do is to basically freeze the program and say that if you have one, okay, but we're not going to approve future provider taxes, and you can't expand programs that you currently have. The Senate, in contrast, to the surprise of most observers, is squeezing down the amount of provider tax that could be collected starting in 2027, to the point where by 2031, the provider taxes will be cut by roughly 50%. This affects red states and blue states It's a major revenue loss to states all across the country, and it shocked most health industry advocates and observers. The next big financing piece that the Senate Finance Committee took on that affects us here in California in particular is the state-directed payments piece. To review, state-directed payments are these extra managed care payments that counties like Santa Clara receive as a way of incentivizing quality improvements and paying to sustain critical services. They're supplemental additional payments in managed care. There's a cap on how large these payments have been historically. In 2024, that cap got raised. Santa Clara County was able to, along with other public hospital counties, was able to take advantage of that and receive additional reimbursement, enhanced reimbursement for these special initiatives. The House bill rolls back that cap to the old level. It says you can't, this enhanced cap, we're not going to sustain it. But it grandfathered in existing funding mechanisms like the kind that Santa Clara County depends upon, and has depended upon. That was the House version. The Senate Finance Committee said something much more radical. It said that we're not going to protect any of these directed payments. We're going to, in fact, roll them back 10% per year until they reach the old lower level. So that would impact public hospital systems in California, very problematic and much different from what the House did. So there are a number of other provisions that are controversial in what the Senate Finance Committee did, but the basic thing to focus on here is that it did generate major opposition from Republican senators. Is there a question? No, okay. So where do we stand now? The first point to understand is the Senate Finance Committee proposal, which again came out a week or so ago, is not the final word in the Senate. It's currently being negotiated with a number of Republican senators who strongly oppose the financing changes. Advocacy also in the hospital community, because of these changes, ramped up significantly last week. A recent study developed by the University of North Carolina Center for Health Research, which was widely circulated in the Senate, said that 338 rural hospitals could conceivably close based on just the House version, without even getting into what the more draconian Senate version would do. There is a block of Republican senators who say they need changes in these provisions. Senator Hawley of Missouri is not normally a Medicaid proponent, is in the middle of that. But there are other senators as well, including Senator Moran of Kansas, again, not normally a proponent of Medicaid, the senators from West Virginia, and Senator Tillis of North Carolina, who's up for re-election, actually circulated last night in the Senate Republican Congress a brochure, a pamphlet, which basically outlined how much individual red states would lose, focused on his North Carolina losses, and said, my state's going to lose $40 billion unless we change these Senate Finance Committee provisions. So there is this rebellion, this revolt going on among Senate Republicans. But we don't know how this is all going to play out for a lot of reasons. It's a very volatile situation. And there are solutions being talked about that would actually not be very good for California. One solution to these cuts in hospital payments would be to create a rural hospital fund or a stabilization fund. They've talked about this, some senators have talked about putting $100 billion into the stabilization fund. So if these formula changes destabilize rural hospitals, and that's what people are rallying around, the threat to rural hospitals, we'll have money to support them and sustain them. So that sounds good on its face, except the problem is people like Senator Scott of Florida has suggested the way to pay for the stabilization fund is to take that 90% enhanced match for the Medicaid expansion population, and let's decrease that and take money from the states that expanded Medicaid, and we'll create a rural hospital stabilization fund. A not at all good idea, and that's part of the danger that we're facing in the next couple of days. We also have the issue of, even if they create a stabilization fund that doesn't cannibalize other critical ACA funding and Medi-Cal funding, how will the administration distribute that money? We've already seen that this administration seems not to be bound by the concept of fair and impartial formulas. Will blue states fair as well as red states? Not likely, given what we've seen. So this is a solution, but not necessarily a good solution. In addition to these kinds of negotiations, I want to briefly touch on the Byrd Rule, which is quite consequential and which we're going to learn about in the next 24 hours in terms of its impact on the Senate. This is the rule that says you can't put into the 51-vote reconciliation bill a measure that is, or a provision that is not budgetary. And the House and Senate Republicans have jammed all kinds of non-budgetary items in there. And what the Senate parliamentarian does when she rules on these issues, it historically means that the provision is dead. So even though the Democrats are in the minority in the Senate and can't kill these provisions on their own, they can and they are appealing to the parliamentarian to strike down many of the provisions and hope that the parliamentarian will. Now, the parliamentarian has already acted on a large number of provisions in other parts of the reconciliation package. SNAP language that would cut SNAP funding for states has been struck down by the parliamentarian in its current form. It may be revised, but in its current form, struck down. All kinds of changes every day being made. The Senate Finance Committee provisions were argued before the Senate parliamentarian yesterday. And when I say argue, the way this works is Democrats and Republican staffers submit to the parliamentarian their arguments. Then they have a meeting where they kind of debate in front of the parliamentarian the pros and cons. And then that same day or a day or two later, the parliamentarian says up or down on the provisions. Senate Finance and our health provisions are current. The arguments were yesterday. We're waiting to hear what the result of that process is. It's possible, for instance, that the FMAP reduction tied to whether or not a state covers care for the undocumented, that could conceivably be struck down. It's one of the arguments the Senate Democrats are going to try to make, because it's really not about saving the federal government money. It's about creating a policy, imposing a policy on states. And we'll see what happens on that front and other fronts as well. So we're waiting for that Byrd Rule process to play out. Meanwhile, the Senate Republicans are talking about getting a bill to the floor this Thursday. That's optimistic, but they want to do it by the weekend. They want to have a vote on the Senate floor by the weekend. They want to pass the bill by no later than the July 4th recess, they say. And the president is pushing the House to agree quickly to what the Senate does and to have a presidential signing ceremony by the July 4th weekend. Assuming the Senate can pass its version, which is a big if, by the weekend, and it's taken up by the House before July 4th, it's possible all this can happen, although Speaker Johnson said about an hour or two ago that he's telling his House members to stay in town, not to leave town over the next several days, but he raised the prospect of a conference committee. He said, we may be able to work these things out, but we may have to go to conference. The president is very much opposed to that. Senator Thune's trying to avoid that as well. But I've talked about a couple of health issues. There are many other health issues. There are literally dozens of other policy and financial issues to be worked through. It's hard to see this happening. I would guess it will not happen. But you do have a Republican Congress that's very deferential to this president, and it's not impossible that if President Trump starts to pressure individual members, we see something happen quickly. Not impossible, but again, unlikely. The other driving factor in terms of a deadline for all this was the debt ceiling limit. Remember, we talked about that beforehand. And we thought an August fairly firm debt ceiling crisis coming, and that would drive a July decision, mid-July decision. That estimate has been revised since we first heard it. Now people are talking about the debt ceiling kicking in maybe August, maybe September, maybe October. And there's no so-called X date, which is a firm fixed date that Treasury says is the drop-dead date. So because there's more squishiness, softness on when the debt ceiling kicks in, we may see this process play out over more weeks during the summer. And again, many issues for them to negotiate, many issues to resolve. Happy to respond to any questions you might have.
Thank you very much, Mr. Golan. That was very comprehensive. And yes, James, good morning.
Yes, I just wanted to share a couple high-level comments. I think Bert did a great job walking through a lot of the details, but just to make really clear what we're looking at locally, the Senate finance proposal would be absolutely devastating to our county organization and to the health care of the residents that we serve. The county's operations in SCVH rely very heavily on directed payments, which would be capped under the Senate finance proposal and not grandfathered. And California as a whole relies very heavily on the managed care tax. And in fact, we were very happy that Prop 35 passed just last year. And even under the House proposal, that would have been dead because it would not have yet obtained the federal approvals required. In either the House scenario or now the Senate scenario, and candidly, we're surprised to see the Senate proposal make the House proposal even worse. We were cautiously optimistic the Senate might make things a little better, but clearly things seem headed in the other direction. We are looking at hundreds of millions of dollars in ongoing revenue impacts to our county health system. We're going to be paying, obviously, very close attention to how this evolves. As Bert said, the impacts to hospitals across the country are significant, and we are worried that the way they address that will be in mechanisms to address the impact in red states and not blue states, which, if you think about it and just take a few steps back, is so morally bankrupt of an approach as a country to take, to think that we would take actions like that that would debilitate healthcare provision in some parts of the country and not others in that kind of way. I mean, it's just deeply, deeply offensive and at the direct cost of people's lives, candidly. But we're going to monitor what's happening very closely. We don't have a lot of leverage or levers to pull on the Senate side. But the bill would then have to return to the House, and we will, of course, keep the board updated as that progresses and we see what ends up ultimately happening. But these specific items that we're talking about represent hundreds of millions of dollars to the county. And so the swings between the House version, the Senate version, and what happens here or there could be really quite significant. That leaves us right now still with a guessing game, but if they march forward with their aggressive timeline, I guess the one piece of good news is we'll have some answers sooner rather than later, but I don't think they'll be very good ones. So we'll keep people updated, but I just wanted to make very crystal clear for the benefit of the committee and the public that regardless of what exact iteration comes out, and there's certainly worse iterations, we are looking at truly devastating impacts to our county health system and to the county organization overall, and therefore to health care for hundreds of thousands of people in our community. There's just no way around that. We'll of course bring forward our best information when we've got something that's not such a moving target, but we're very, very, very concerned.
Well, James, I agree with everything you said, except one thing is you mentioned hundreds of millions of dollars impact. I think we also have a back of the envelope calculation. I think we're talking about actually potentially over $1 billion.
Cumulative impact,
Cumulative
yeah.
impact,
So, when you're looking at, and this is one of the reasons where we are so displeased at the approach the state is taking to Medi-Cal, because what we were trying to explain to legislators is to cut on top of the same program. So when you stack all of it together, right, and you look at these federal proposals, the federal administration proposals, the disenrollment proposals and the work rules and those impacts, and you add on top of that the state Medi-Cal impacts, yes, we are definitely looking at in the range of $1 billion or more.
Right, and I think that's sometimes when you talk about millions and billions, and in this case, they're talking about $1 trillion cut, right? These numbers are so big. And when you have too many zeros, I think a lot of people start losing understanding of what that means. And I want to emphasize that because if we're only talking about $100 million impact, at this point, that would be even a good news for us.
That would be amazing news.
It's amazing good news. Not that it'd be good news, but compared to what's being proposed, because what we talk about is 10 times that, right? So I just wanted to emphasize the significance of this because, I think that thing is like, let's say the operation of O'Connor, for example. Not saying we want to close any hospital, but even if you were to close O'Connor, something like that, what we're saving is only a few hundred million. It's not even enough to cover. I mean, that's how big a deal this is.
Yeah, I mean, I think another way to put it is the cumulative magnitude of what we're facing if these pieces come to fruition is absolutely catastrophic and will mean a radical shift in what we're able to do as a system and the services that we can offer. There's no way around that. No. That magnitude of impact is very much to be determined, right? The difference between the Senate version and the House version, whether this whole thing makes it through, the magnitude of that impact is to be determined. But we're talking about deeply significant impact. We're talking about tens of thousands of families in this county losing health care. And we're talking about the loss of access to critical services to the entire community. There's just no way around those pieces. So we will see how it all exactly shapes up. We will continue to do everything that we can do. But certainly, if the Senate version were to come to fruition, and anything that looks like what the Senate Finance Committee put forward, it would be just devastating.
Right. So, Ms. McGillen, while you're here, the federal budget, as we know, the federal government runs in October 1st to September 30th fiscal year, which is different from ours being July 1st to June 30th. If the worst case scenario, let's say if Senate version actually passes, right, it would come into effect October 1st. How would that affect us budget-wise? Is that going to be implemented in stages, or is it all happen?
It's going to be in stages. So, for instance, on the directed payments piece, there's not a clear effective date. It simply directs the Secretary of Health and Human Services to change these directed payment agreements, which expire at different points in time, and make sure that they ratchet down and go back to the lower cap. So that'll play out over months or years, and that's true of almost all these provisions. So this is the challenge, I know, for the county from a budgetary standpoint, figuring out the ripple effect at the federal level, which again starts with the bill passing, but then there's going to be regulations, rulemaking, guidance issued. Then the states have to absorb that information. There'll be a special session, I'm quite sure, of the legislature to deal with health care, and there'll be a rewriting of the state rules on how Medicaid operates, which the county will be heavily engaged, I'm sure, in trying to influence. So you see all the different stages and steps. That's why we can't give you a date certain for impact.
Thank you very much. Yes, Vice Chair?
Thank you, Chair. Yeah, definitely devastating news. And I just wanted to, I guess, go back to its impact on us, the county. Earlier, there was a $1.9 billion number that was, and was that the total?
The 1.9 was the total for this current year that's about to end of their total amount of Medicaid funding that we get as a county organization.
So it would be some, hopefully not all of it, but some proportion of that.
Yeah, so there's two things. One is that number is going up next year because we're getting revenue increases. We've added a hospital during, most of the way through this fiscal year.
Right.
So our baseline estimate of Medicaid is a number that's more like 2.3, 2.4 billion for the upcoming year. And then of that, with all of these cumulative changes, and as Bert said, they're not all going to hit like that immediately, but a lot of them would probably hit during the course of the next fiscal year 27.
Okay.
And one of the big unknowns is enrollment. because a big piece of the revenue is based on how many folks are in Medi-Cal, and we are quite concerned that between the work rule changes and the state's changes to the state-only program, that there's going to be a significant drop of people in the program. So that is kind of separate and apart from the direct cuts that we're talking about here, from the directed payments and the other pieces. So those will kind of trickle in at different moments in time, but in aggregate, if you stack all of those together, based on the Senate finance proposal, we think that it's about $1 billion.
Okay. Regarding the Senate bill, it would go back to the House. The House passed their original with one vote. What is the likelihood of, if you're, crystal ball, in light of how the House members voted, do you see the Senate version barely passing, not passing, getting more support? I remember some Republicans wanted even more deeper cuts on the House side.
And there are senators that want deeper cuts too. There's a Ron Johnson block that wants deeper cuts. So it is a hard crystal ball question to answer, because you have competing factions on every issue in both houses, and there's a one-vote margin for the first passage in the House, and the Senate can't afford to lose more than a few. So while the Senate Finance made the Medicaid proposal worse, as we've all discussed, there's a block of 5, 6, 7 senators who want to improve it. Now, I mentioned before that there are ways of improving it that aren't good for blue states where we're left out. But there are also ways of improving it where you just go to the basic formula and you say, this is too draconian. We're going to allow for that. We're going back to the House version. We're going to allow for grandfathering. We're not going to immediately disrupt 40 states' provider fees and all these different mechanisms. So there is a way that they prevail and that the hardliners get satisfied. There's so many other non-health issues in the bill. The other thing to bear in mind is we're focused only on health here, as we should be, but there are a lot of other, there's almost every aspect of the federal government is tied up in this bill, and there's trade-offs going on with other issues. So the state and local tax issue, that question, which has been in the middle of the controversy, that could kill the bill in the House if the Senate doesn't go along with the increase in the deductibility limit that the House members are demanding. There's a small block of them. And even though it's not a health issue per se, it could cause the system to slow down enough, the process to slow down enough for us to get some concessions on the health side before all is said and done. So hard to know. And again, I would say this: if they end up passing it pursuant to the president's timeline of July 4th, we're more likely to end up with a bad result, and we'll probably do better if it slows down and there's a longer, more labored negotiation. That's the best I can say.
Right. Thank you.
Thank you. Let's go and open up to the public. Anybody would like to speak on this item?
For all of item 5?
Yes, correct.
I have no requests to speak on item 5.
Okay, if that's the case, let's see if I have a motion to receive the report.
Yes, I make a motion to receive item 5 report.
And I'll second that. Let's take the vote.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Thank you very much,
Thank
Nicole. Thank you. Number 6 here is the receiving the monthly report from the Veterans Services Office relating to Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program. And today we have our BSO Director, Darlene Escalante. Good morning. Let's try again.
Good morning. Can you hear me okay?
There we go.
Perfect. Thank you. Good morning. My name is Darlene Escalante. I'm the director for the Veteran Services Office, and I'm joined by our management analyst, Stephen Fisher. Today, we'll be providing a report on the implementation of the Staff Sergeant Fox grant. But before we begin, I'd like to take a moment to honor the individual behind the name of this important grant, Staff Sergeant Parker Gordon Fox. Staff Sergeant Fox was a dedicated U.S. Army veteran who served with distinction, but like many veterans, struggled with the invisible wounds of war. On the screen, you'll see a picture of Staff Sergeant Fox. He tragically died by suicide in 2020 at just 25 years old. His story and the stories of many like him highlight the urgent need for targeted mental health support for veterans. In response, Congress established the Staff Sergeant Fox Suicide Prevention Grant Program, not only to memorialize his service and sacrifice, but to build a lasting system of care. This grant empowers local agencies like ours to connect veterans in crisis to essential mental health services, stabilize their lives, and ultimately prevent further tragedies. We are proud to be part of this effort through our Veteran Services Office, and today we'll walk through our implementation strategy, outreach efforts, and how we aim to honor Staff Sergeant Fox by helping veterans in Santa Clara County. The purpose of the Staff Sergeant Fox Suicide Prevention Grant is to serve as a bridge connecting veterans with long-term sustainable care. Under the existing Prop 63 MHSA grant, the VSO has already completed assessments of 402 veterans, with 162 entering case management under the program. As 230 of the assessed veterans expressed challenges covered by the Staff Sergeant Fox program services, the Staff Sergeant Fox program will enable the VSO to expand support to these veterans in need. Our immediate goal was to begin formal assessments in June, prioritizing veterans already in our system. Next slide. This timeline provides an overview with target metrics per month. The timeline is developed under the initial program timeline through the end of the federal fiscal year on September 30th. Should the program be extended, an updated timeline will be developed based on the duration of the extension. All right. Staffing is critical to this program's success. Our first extra help social worker began on May 27th. The second social worker was intended to begin on June 23rd. However, due to delays in the LifeScan background clearance process, this has been delayed to a target date of July 7th. Once our grant extension has been approved, we plan to convert these positions to term limited roles, ensuring continuity throughout the program. Our timeline for enrollment and services structured to scale up gradually. Screenings began on June 2nd with a target of 10 screenings and 5 enrollments. We are pleased to report that with just the first 2 full weeks of assessments, our social workers has not only met but exceeded that target, with 16 veterans screened and 5 already enrolled in the program and have already provided emergency support for housing, excuse me, marking the first use of grant funds to directly support a veteran in need. Under the current program duration, we plan to screen 20 veterans and enroll 15 total by July. By August and September, we aim for 40 monthly screenings and 60 enrolled veterans by September 30th. Effective outreach is also critical. In June, the social worker participated in 1 weekly outreach day and 3 planned events. Throughout June, the social worker has exceeded that with events supported on the next slide. In addition to outreach events in the community, the social worker has leveraged standing community outreach at the VSO, including the mobile dental program, along with the VSO's walk-in days to exceed the initial target of screened veterans. Future outreach will include partnering with social services agency departments to reach veterans already utilizing county services. In July, we'll expand to 3 outreach days per week. By August and September, each social worker will conduct outreach 3 days a week at targeted community locations. The social workers already participated in several outreach events. On June 6th and June 20th, she joined the VSO's outreach at the Gilroy Veteran Memorial Hall. On June 12th, the VSO, in partnership with the Palo Alto Healthcare system, hosted a Women's Veterans Day event at our Julian campus. And most recently, we provided outreach at the Santa Clara County DMV on June 23rd. These events have been instrumental in building trust and spreading awareness of our services. Our emergency support structure focuses on 4 critical areas: housing stability through emergency rent and utility assistance, daily essentials like food and childcare, career development with job preparation and attire support, and emergency medical needs such as prescription and transportation. All payments are tracked and documented thoroughly to maintain compliance and accountability. We are currently preparing our grant extension application with support from FMS, along with a renewal application due on July 18th. If approved, the extension would allow for existing funds to be used through June 2026. The renewal application will provide additional funding for the program continuing past June 2026 for an additional year. The extension allows us to fully utilize the awarded funds, while the renewal would open up opportunities for expansion. Future reports will include data on direct impact of the grant on the enrolled and case-managed veterans, including data on current outcomes and overall progress. This concludes our presentation, and we'll now answer any questions.
Thank you very much, Charlene. Let's see if there's even the public would like to talk about this issue.
I see no requests for item 6. Just double checking. No requests for item 6.
Okay. Let me see. I don't see any lights here. Yes, Supervisor. Yeah, my Vice Chair? Yes, go ahead.
Thank you, Chair. Thank you so much for the presentation and your good work. Just trying to understand the numbers a bit. So there were 402 intakes, 162 resulted in referrals, 230 veterans facing challenges, 85 with mental health issues. And in terms of our screenings and enrollments, are those from the 402 intakes, or is that in addition to?
The 402 were assessed individuals. Screening and assessments are very separate.
Okay.
Of the screened veterans, I believe we had over 2,000 screened veterans, but 402 resulted in assessments.
Okay. So then is the goal to reach all 402 by the end of September, is it, when the funding?
No, the program goal for the staff, those numbers are related to the Prop 63 mental health grant that the our other social workers funded through.
Okay.
Utilizing that
Okay.
data, we are using that data to expand this Staff Sergeant Fox grant.
Okay,
The
great.
program target for the Staff Sergeant Fox grant is 100 enrolled veterans.
Okay. So, and we are at by August, you expect 60, and most likely by September completing. Okay.
Correct.
Great. And you have your second social worker coming in July 7th.
Correct.
All right. Thank you.
Thank you. And do you have a motion?
Yes, I will make a motion to receive the report.
And I'll go second that. Yes, thank you, Darlene, for the very good report here. Thank you for extremely important issue because suicide is certainly one issue that our veterans are facing every day. And one of the things is our office have actually attended the Women's Veterans Day event at the SSA facilities over Julian Street. Also got to meet the new social worker, Cynthia Estrada, so very excited to have her on board. And that the program is now off the ground. We talk about the goal of being 100 veterans into the program for services. Is there actually a cap to the number of veterans for this, or is this just a goal whereby we could actually refer more people into this program? It turns out that all 100 spaces are filled.
Good question. There is not a limit. It's not limited to 100 veterans enrolled. As long as the funding continues, we can add to that number.
Okay. I'm just trying to see, looking at the situation, because a lot of the veterans are technically supposed to be served by the VA, but of course there are different scenarios where an individual could be denied service by the VA as well. And what happened afterwards, and what is the role that our organization or maybe our behavioral health department can play if folks are veterans but they're denied service by the VA?
Certainly. The only eligibility requirement for veterans to be enrolled within VA healthcare is a discharge other than dishonorable. So for veterans with a dishonorable or a discharge
Bad
due
conduct.
to a court-martial wouldn't be eligible for VA healthcare, in which case we would refer them directly to behavioral health if they meet the eligibility requirements. In addition to behavioral health, we have partnerships with community organizations such as Swords to Plowshare and Open Doors to Future Possibilities, as well as the San Jose Vet Center.
Yeah, thank you. I actually just attended last week the luncheon hosted by Open Doors. And it's interesting, you mentioned social plowshare. That's one of the first work that I did while in law school to file an appeal. And learning that process of trying to get an appeal of these disability benefits is extremely complicated and certainly requires lawyers and whatnot to get through the program. So thank you. How much funding is allocated per veteran for the emergency rental assistance? And is this part of the $5,000 per client for the critical services?
So the total funding for third-party payments, I believe, is $165,000, and I don't know exact change. It's $165,000, and there is no limit to how much of one veteran can receive. How the only limitations that were set were for childcare, which is capped at $5,000 per veteran per fiscal year, and employment services is also limited to $750 per veteran per fiscal year. Those are the only limitations.
Got it. Okay. So today I won't be adding any additional direction, but I certainly want to forecast that in a future HXC meeting, we will work with you both to assess the progress of this program with more results-oriented data to see how these veterans are actually doing in terms of enrollment in this program. Hopefully, if we actually hit the 100 goal and even go further, that would be actually, in that sense, a good news, right?
Absolutely.
Great. All right. I have a motion, I have a second. If no further comments, let's take a vote.
Vice Chairperson Abigail.
Aye.
Chairperson Lee.
Aye as well. Thank you very much, Tony.
Thank you.
Okay, moving to item number 7, which is a report from the Santa Clara Valley Healthcare relating to the acquisition and integration of the Regional Medical Center, including associated impacts to the Santa Clara Valley Medical Center Emergency Department and the trauma volume. Yes, Dr. Fong.
Good morning,
Morning.
Supervisor Lee and Supervisor Abegoga and the committee. I'm here on behalf of Paul Lorenz. I believe you have the written report, but I would like to highlight a couple of items. So May is the second full month that Regional Medical Center has come under the leadership of the county and SCVH. We continue to see significant patient demands. The average daily census at Regional Medical Center in May was 159, which is up from 138. We also have seen an increase of almost 6% of ED volume at Regional Medical Center. And in spite of the increase in volume at RMC, we have not seen a significant decrease in volume at our other hospital. And in fact, as a system, we have seen increase in patient volume and patient census. So clearly, the decision from the board and the county leadership to acquire and run Regional Medical Center was absolutely the right thing for the community. And I'm happy to answer any questions.
Yeah, thank you very much, Dr. Fong. Yes, Vice Chair, go ahead.
Oh, thank you, Chair. Thank you so much for the presentation. It's encouraging to see the increase in use, and clearly shows that there was a need there that we're now able to fill. So very excited to see that. I wanted to, I'm happy to see the increase, the daily census increasing. It looks like, so our target is 179, and was that within a year that we were looking to get there? And given that it looks like we're actually ahead of target, we might hit that in the next month or two. I'm thinking that's positive from a financial perspective.
Yes.
Is that?
Yeah, it is. We're doing, yes, the regional is doing very well. It is very busy. And it is positive from a financial perspective because so much cost associated with running a hospital is fixed cost. And so having a higher volume helps cover those fixed costs. That being said, of course, like any of our safety net hospital systems, it's not going to, turn a profit on its operation, but is going to be in much stronger financial shape than it would otherwise. So we will come with updates on that probably around the time of mid-year because we need to see several months of progress. And we're only now just beginning to get the first receivables, right? Because it takes several months from the date of service delivery to actually starting to get collections coming in. And that's just begun as well. But all the trends are very favorable operationally, very favorable financially. It is exceeding projections, and we're very, very pleased.
And then could you remind me what the 179 number, the target is based on? Is that based on current operations? Like what happens if we exceed that?
Sure. So that's the number of patients that are admitted overnight. They do a count at midnight. If we end up exceeding that, there would be, of course, increased revenue associated with that, but also there's capacity. And one of the things that we're continuing to do is to staff up to meet capacity. And that's getting to be pretty full for this facility. So there is a point at which you don't really want to be running on it. Of course, there can be surge times, but it's not like we're hoping to have a patient census of 300 there that doesn't even have 300 licensed beds, right? I do think we will. I do think it's reasonable that we may end up on a consistent basis higher than our projection, but not by massive. I don't know, Fong, you have different perspective to share on that, but we wouldn't be looking to go that much higher than that number.
Yes. So Supervisor, yes, I think Mr. Williams accurately state that. I think the 179 number come from our assessments of the patient need potentially that would come to RMC, and also based on our experience at O'Connor. That's why initially we projected that the 179 would be reached at the end of the year. However, given that we're doing so well, is helping support the health system better. But we do not foresee that the volume would go significantly higher.
Great. Thank you. Thank you very much.
Thank you. Let's see if there's anybody in the public who would like to talk about this issue.
I have no requests, either in person or on Zoom, for item 7.
All right, go ahead and close that. Yes, Dr. Fong, thank you so much for the explanation. So a couple of things. As pointed out by James, even though we have more patients, that does not mean that we'll turn to profit. But I think the takeaway, if I'm wrong, if you could correct me, is that the cost per patient will go down. That's the good news.
Yes.
Right? Therefore, our system is becoming more efficient.
Yes.
You have that. That's the reason why more patient in this case is a really good news, correct?
Yes. So the cost per patient will go down because of the fixed costs. And I think there's a couple lenses that are important to view this. To me, the most important lens, given that we're a government agency, is what the census actually represents, especially given that it has not gone down in our other hospitals. This is literally health care delivered that otherwise people weren't getting.
Exactly.
So number one criteria for us is, are we taking care of people? And that's how we're different than the HCAs of the world whose number one bottom line has to be profit.
Shareholder return.
So, right. So our number one is service delivery. The financial piece, of course, is absolutely vital because that's how we sustain that healthcare delivery. And so we are very pleased that regional is moving so quickly in that positive direction and spreading those fixed costs. But we have to recognize that our two largest service lines, right, our two largest payers are Medi-Cal and Medicare, and both Medi-Cal and Medicare don't cover the full cost of care. And I want to just say a piece on Medicare, because I think this is the one that's not as well, people understand the Medi-Cal piece of that kind of more intuitively. But something interesting has happened over the last decade. I kind of wish we still had Bert here maybe to talk about this kind of more from a national perspective. But we've increasingly become the hospital system that takes care of people on Medicare, because Medicare rates haven't kept up and the private systems are pushing away Medicare patients too. And so it's not just a Medi-Cal story and of those who are on that program, but it's also a Medicare story, and that's especially true at regional, where the payer mix is actually more Medicare than Medi-Cal. And that's continued to be the case even post-acquisition. And we expect that that will continue to be the case as significant. So we're actually, not only are we, of course, far and away the largest Medi-Cal provider in this county of all residents, we're also the largest Medicare provider of all residents. And as we have an aging population, we are the safety net hospital for Medicare too. And that story hasn't been as well told in public, and is something that, just at a bigger picture, should concern folks, because the Medicare cost reimbursement levels are a problem nationally and statewide as well.
No, thank you so much, James. And I was able to also say, Dr. Fong, thank you for the staff there for giving us a tour. I was there a month ago with some of our congressional representatives from the offices to see the various beds that's now open. I believe the ICU beds, I think it started with one wing. We opened up the second wing, and then they were talking maybe even a third wing opening up, right? So my numbers might be off, but you could correct me. I believe it was like 12 beds for the first wing that was open when we first got in. Then they opened the second one, which was great. It's already full, basically.
Yes, 24
right, 24.
beds.
And they're thinking about opening a third one because of the census that we might need the third wing, which is another 10. And do you know when that third wing might actually be opened? Is fairly soon, you think?
Supervisor, I don't have the exact date, but I can get back to you on that.
Okay, good. Thank you. Yeah. So I just want to see, and I just want to huge compliment to our staff how fast this has been. We opened this on April 1st. We've got our trauma system started, at noon that day after our ceremony, and it's just been going gangbusters. And the trauma level 2 is started immediately day 1, and that's just really unprecedented in a good way how fast everything's put together. The other area that I get to visit is the labor and delivery area. I mean, the facility seems to be in fairly good shape. I know we are still working on getting that together. Do you see that will be open in the next 6 to 12 months, or what's the plan at this point?
Yes, Supervisor, our goal is to have labor and delivery open by the end of this calendar year. We are already actively working on staffing. By the time when it's open, we will have 24/7 anesthesia, obstetrician, neonatologists, and other staff to support the service.
That's great. Yes. Looking forward to see some babies
Yes.
soon at the Regional Medical Center. We have been missing them for at least 5 years now. I still remember I was out there holding the signs, protesting against the closure of labor delivery, 5 years ago. Now, we talk about the emergency department, ED, being very busy. Now that the Regional Medical Center is opened, do we see that the wait times of our emergency department on other hospitals decreasing due to the fact that now that we have RMC opened?
Yes, Supervisor Lee. Actually, with the opening of RMC, it actually has significantly relieved the crowding of our other facility. In fact, I was just looking at VMC and O'Connell ED wait time, which is basically from arrival to discharge time. VMC number have gone down 13%. O'Connell wait time has actually decreased by 20% since
Wow.
January. And then when you actually look at RMC, prior to the wait time between March and May at RMC ED itself has gone down 48, almost 49%. I think that speaks to the fact that we made the investment, we bring in specialist services that were in essence, a desert at RMC, and that allow the ability for patients who need to be admitted to the hospital that need specialists can be admitted, and also with the enterprise approach of leveraging our sister hospital to be able to admit patient to other facility within our system as well. I think inter-facility transfer within our health system has gone up 50%. So I think that significantly also help with the access at RMC as well.
Great. No, this is really good news. Absolutely. I know this is not your area, but I would imagine the wait time for our ambulances to get them unloaded also would be going down. But that's a question from one of your colleagues that would be, next item that we could talk about. On the data migration from HCA Healthcare Managed Applications to ours, I know things are moving very quickly with the IT side. When will those migration, do you believe, would be complete?
Supervisor, we do have the transition of service agreement in place with HCA until April 1st of 2026. However, our TSS team has been doing an amazing job. I think they have set a target for themselves to be complete with the transition by the end of the calendar year as well.
Great. All right. Thank you very much, Dr. Fong. We have done certainly a lot, and yes. Supervisor
I'm
Abacoga?
ready to make a motion, so.
Go ahead, make the motion, yes.
Happy to make a motion to receive the report. Thank you.
Yes, very happy to second this good news report. We need some these days. Thank you. Go ahead, let's take the vote.
Vice Chairperson Abekoga.
Aye.
Chairperson Lee.
Aye as well. Thank you very much. Okay, we have item 8 approved already on the consent calendar, so moving to item number 9, which is receive report from the Santa Clara Valley Healthcare relating to the efforts to address improper disposal of medical waste and confidential patient information.
Supervisor, we have Dr. Brian Macbeth, who is our health system director of quality and safety, to present.
Good morning, Dr. Macbeth. Go ahead.
Good morning.
Good morning.
Good morning, Supervisor Lee, Supervisor Abacoga, and the committee. Thank you for having me. And I believe you're in receipt of the ledge file and written report, and I won't read through it all, but I will highlight a few areas mainly focused on our second quarter work around this project. And I'm going to reference 2 of the vendors that we're working with. You may recall that since January, we've had Professional Renovation Services, PRS, working to do 100% waste audits at our 3 facilities that were cited, and so that work continues. But on top of that, we also have been working more recently with NG Impact, which is a well-known vendor that has been successful with Kaiser and other health systems and entities working on these kind of waste disposal challenges and sustainability. So that contract was approved in February. They've been on site at our facilities starting in March, initially doing audits and assessments, and it was the first kind of visibility we had into the clinic performance too. So just to be clear, although it was our 3 hospitals at the time that were cited, this project encompasses now our 4 hospitals, as well as all the ambulatory clinics and custody health waste disposal too. So we're taking a system-wide approach to this. So NG came in starting in March and continuing in April to do these audits and really establish a baseline of performance of where we are. And then in last month in May, really shifted their work to the WASP program. And WASP is this acronym that stands for Waste Assessment and Standardization. And this is the component that's really around education, it's around sustainability, it's around the bin optimization and consistency. It's about simplification of the process for all our staff to reduce the likelihood of making mistakes. So there's a lot of educational work in May, presentations to leadership, and then I'm going to highlight in June. So just a few weeks ago, they set up essentially teaching sessions at all our hospitals and our clinics. At Valley Medical Center, 2 days, at the other hospitals, 1 day each, where they had open teaching for 4 to 5 hours where staff could drop in, and we saw an incredible engagement around this. So we weren't taking attendance. We really left it flexible to try to engage staff on their own time, but we're estimating in the thousands of staff that showed up at our 4 facilities and all the clinics as well. So it was an opportunity to kind of go through understanding like how to sort these different waste products in the hospital setting, a lot of specificity to units, to things like pharmaceuticals and sharps and protected health information. So that was enormously helpful. And going forward, where we're at with them in the next few weeks is there's going to be ongoing education, setting up asynchronous opportunities similar to what they did for staff who weren't able to attend. They're doing vendor walkthrough debriefs around each site in the next couple of weeks, and essentially laying out kind of what they found with the audits, and then assessing the gaps. And they're producing dashboards for each site, listing out line items with stepwise process on improvement. So what needs to be done for each given unit. The bins that need to be acquired, different facilities, issues, the teaching, and so line items that each unit can address in a stepwise fashion, and then accountability around a dashboard that's updated on a regular basis. So, and then there'll be more audits. What we're looking later in the summer and into the fall is to sunset PRS and that contract, and then shift to a sustainable model where we have this program implemented across the system. And NG is continuing to work with us around audits and making sure that we're in compliance going forward. So I can certainly speak to more detail to any of those elements where we are currently, what we're projecting going forward, but I think we're in good shape, and we'll be updating the DA as well in August. We have that on the calendar.
Yes, thank you very much, Dr. Beth. Let me see. Vice Chair, you have some questions on this one?
Okay, thank you.
Sure.
Thank you so much for the presentation. It's good to see the progress being made. I just wanted to ask about the audits. Is it 3 months that we've conducted them? Do you see the data that's showing a decrease or improvements in what's being discarded?
Yeah, we do see certainly improvements, and the total number of potential findings has gone down significantly from our start with PRS. And I think we're expecting in the next few weeks, as we start to see manifestation of the teaching from NG, a significant decrease too. Mm-hmm. There's a little bit of a lag in that data, so it's about 2 weeks, 10 days to 2 weeks behind. But so I think we're going to see an ongoing improvement. But yes, certainly since January, those numbers have significantly improved from the several thousands, for example, at Valley and O'Connor, down to about 1,200 roughly at those facilities. St. Louis has shown improvement from 1,000 down to like under 100 in recent weeks. So really some market improvement. And as well, we have the baseline now around the clinics, so we'll be able to report back on performance across all the institutions in the health system.
Great. So is this now intended to be ongoing, or just part of our operations to conduct the audits? Maybe, hopefully, as we continue to see the numbers decrease, maybe not as frequently, but it's just a matter of practice, regular practice for us.
Yeah, I mean, it's really about building it into the culture of how we take care of waste. And there are different components that we've been working with the staff around, the environmental impact and so forth, educating up. But it is kind of a shift in focus, and it's both about compliance, environment, it's about staff education and engagement. So I think we're going to continue to need to do audits with NG, that vendor, probably for the next 6 months or a year, but eventually, and maybe even spot audits internally after that. But it's about building it into a sustainable, ingrained culture of responsibility around these practices.
Right. And then do we have a target we have to reach, or I'm just wondering in terms
Yeah,
of.
it's a great question. So NG has spoken to like a benchmark or an expectation of getting lower than on these audits 10 items per 100 pounds of waste. So that's kind of the measure that they use.
Okay.
We may not get to zero at any point. We have a
Sure.
big system. However, compared to what we were seeing in the DA's photos and findings, we are already markedly improved over that, and we have expectation that we will be compliant at that level. Yeah.
Okay, great. Thank you so much.
Sure.
Thank you. I do have a couple of questions regarding the bins.
Yeah.
When it comes to emptying the bins, how often are they being emptied? Is it like a daily basis or more than once a day? I just want to see if there's any type of a way we can monitor a little bit more frequently to avoid the wrong things being the wrong bin.
Yeah, that's a great question. And it's really specific to the type of waste that's being disposed of. So some has to be, for example, around PHI and the regularity of disposal of this material, it's something that we want to make sure is being removed from areas in clerical areas where it may not be secure. And so part of it is building bins that are closed off and then removing it on a regular basis. And then other things are removed on a regular basis around sharps and pharmaceuticals and so forth. And so we work with different contracted vendors around the removal of that material, and it's really specific to the areas. And if you would like more detail, we could give kind of a roadmap of like the regular kind of removal of those waste streams.
Right, and basically also is that, let's say if even they remove, say, once a day, is there any protocol that say if a bin appears to be full, would they be able to remove sooner,
Yes.
for example? Yeah.
Yeah, so staff, some of the education is certainly getting staff to communicate with the EVS or environmental services to address full waste bins, especially around sharps or something that, as you try and put more in, could be potentially a safety hazard. So I think staff do a pretty good job of that already, but there's always room to improve. And then there are also areas that just get regular they all get regular pickups, but there's the ability to escalate for earlier pickups as needed.
Right. My understanding, correct me if I'm wrong, is that in basically most rooms, they would have the regular trash and the biohazard. Those are the two main ones that you get. But then, of course, there are other bins as well, right? But then I guess the question here is, how are we putting those in location? Because folks are not going to walk outside one or two rooms away to dispose of a piece of trash when they could just do it quicker. So I'm just trying to figure out if the bins are not there, is there any regulated, is there some protocol? So how far distance of the other bins are being located, or?
Yeah, some great questions. So I can add some more detail. Just on the first piece around the trash and the bio waste, we pivoted right at the beginning of our work around this to identifying certain high-risk areas that we were not going to have trash at all, essentially. So like our operative suites, our labor and delivery, the procedural areas. So we did pivot initially to giving staff only one option, essentially, for the bio waste, because we were seeing such a high level of concern around that. You're absolutely right, like on the next point, that we need to make it very convenient for staff and simple. And so another theme that NG has kind of brought to this is consolidation. So for an example, commingling of sharps and pharmaceutical waste is part of the process that we're building out right now. There's education and there's bin consolidation that goes into that. But essentially, when we can break that from a pharmaceutical container and a sharps container into one blue container that will go in all rooms and will encompass that waste stream, that'll make it simpler and easier for staff to comply.
Right.
And then to your point around, the other things, the less common, we don't put like disposal bins for controlled substances or chemotherapeutics in every room. However, in the soiled utility rooms where they're concentrated, we have to look at how those are organized too, to make sure all the labeling is consistent across the system and make sure that staff, especially in areas that use those materials, have ready access and don't have to walk a long distance. So yeah, those are some of the considerations that we're working with around NG and thinking through as we build this out.
Great. Thank you very much, Dr. Beth, for a lot of information on this trashy affair. All right. Let's see. May I have a motion to receive report? Vice Chair. Oh, I'm sorry. Yes. Do we have any public who'd like to speak on this?
Confirming no request to speak on item 9.
Thank you.
Great.
All right,
I
let's
will
take a
make a motion to receive this report. Thank you.
I'll go and second that, and let's go take a vote. Thank you.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well. Thank you
Thank
so much. All right, moving to item number 10, receiving report from the Emergency Medical Services Agency relating to the organizational activities, opportunities, and progress. Morning. This morning we have our EMS Director, Nick Clay. Welcome.
Good morning, Supervisor Lee.
Morning.
We have our EMS quarterly report, and just to follow up on your earlier comment, the ambulance patient offload delays have gone down significantly. A lot of compounding factors that play a role in that, but certainly Santa Clara Valley Healthcare's systems engagement and certainly regional played a significant role in supporting that reduction. Other than that, we're happy to answer any questions on item 10.
Thank you so much. Let's see, Vice Chair, go ahead.
Thank you, Chair. Just a couple of questions regarding the EMS, the PCR to Epic project. Through what is the expected timeframe for the approval, TSS approval process and implementation of?
So for the Santa Clara Valley
the
Healthcare
transfer.
System, Supervisor Abekoga, that process could take up to 4 months. So it's initiated about 2 weeks ago.
Okay.
So waiting for that next steps, and then we have a 120-day window in which to implement it for the system.
Okay, great, thank you. And then the Nurse Navigator program, I think it was before my time that it was started, but are you able to provide what our usage volume has been, and then what is the expectation for the timeline for a full rollout?
Supervisor Abekoga, we can, the details for the usage have been about 100 cases so far.
Total.
Since November 13th till May 30th, I think June 1st. So 100 uses so far. Again, it's a very small region in which it's being implemented with a lower call volume. Certainly a lower usage than expected.
Mm-hmm.
We are looking at expanding. There's 2 aspects to it. There's one aspect that goes through the emergency medical dispatch system in which the 911 dispatcher can engage. And then there's the aspect in which the field providers, upon arrival and assessment, can initiate a nurse navigator engagement. We are looking to roll out the field referral, the paramedic and EMT-led program over the next several months, increase our training with a January 1 system-wide launch in which every jurisdiction and everyone in the county has the opportunity to have that access to care.
So right now, you call 911, they transfer you over to the Nurse Navigator? Is that, or is that how the program works, or could you explain?
Generally speaking, yeah, in the areas and where the program is initiated, which again, just for reference, is the city of Gilroy, Morgan Hill, and all of the Santa Clara Fire District areas. So and all those go through our county communications center, and the patient's given an option. So they're asked a series of questions, which is the emergency medical dispatch process, and then if they meet a certain criteria, they're offered the opportunity to engage with a nurse navigator. And at that point, they can accept it or decline it.
So then, would you say most folks are declining it?
There's opportunities for improvement in terms of the dispatch process. Dr. Darcy, do you want to talk to our next steps?
Okay. Thank you. Hi, Dr. Darcy. So it's right now the main barrier is more in reaching the patients that are eligible. Initially, when this rolled out, the idea was that if we could offer it to everyone, there would be a certain percentage expected of patients that would meet the eligibility criteria to be offered the service. And then they would have this expansion of services of what they could choose from after speaking with the nurse navigator on that side of the call. And so right now, it's not necessarily that people are saying no, it's that we need to offer it to more patients. That's really where we're seeing the potential that has not yet been reached.
So I guess, and if you can indulge me, I've called 911 many times for on medical calls, but so if I call 911, I explain the situation, then the dispatcher would say, oh, this seems like it could be handled by a nurse navigator. Could I send you over to that? Is that the process right now?
Yes, if those criteria are met, the service is offered.
So then how would you be able to offer it to more people? Because if you're basing it on just the calls, right, you're already reaching pretty much everybody who's calling.
Yeah, I think I would go just to simplify it. I think the net we cast was very narrow. So as you sort of ask these series of questions, you get to a very small list of folks. Through Dr. Darcy, we're looking to expand that list more safely so that rather than having 4 options of caller types, maybe we have 12 options or 30 options.
Okay.
And to offer it to the entire county, which we aren't doing currently.
Okay. So if we roll it out to the entire county, again, is it a pilot program? Just to be frank, 100 calls or 100 cases in 6 months, even and then county fires jurisdiction is quite vast. Maybe not half, but it's a pretty small call volume, frankly. So, what are our benchmarks? What are our targets? How are we going to determine whether this is worth the investment or not?
Good, James.
Frankly?
Yeah, a couple comments on that. First is at its ideal implementation, we never forecasted that it would be more than maybe 10% of the medical call volume. Okay. So it was never intended to be a significant percentage of the calls, but one of many strategies to try to decompress the system overall. Okay. County Communications, which is the only dispatch center where it's been implemented, collectively, countywide, handles about 20 to 25% of the overall 911 system call volume, but even there, it's not been implemented for all of the jurisdictions within County Com where there is emergency medical triaging happening. Like, for example, Milpitas is one of the providers by contract, and it's not been implemented there. So I don't know what the rough percentage of aggregate 911 calls where it's been implemented is, but that's probably, my gut sense is closer to 15% of probably countywide 911 volume. So the goal at the initial stage was to make sure that things were running smoothly. And then we've always understood that to the extent we were actually going to see any system-wide benefit, we actually need San Jose to implement it. Because San Jose is a majority of all 911 call volume in the county. One of the big challenges that we have is San Jose today actually has a very poor triage rate for medical calls, period. So if you think of nurse navigation as kind of a supplemental addition to your general triaging process, where you do emergency medical triage and you determine whether you need to send somebody code 3 or code 2, et cetera. San Jose right now in their 911 center is only doing that triage on about 2/3 of medical calls, like 64%, which is very, very low percentage. That number is well above 90% at County Com. So that is kind of a first threshold issue, and then you would layer nurse navigation on top of that as basically for those calls where you've already screened them out as not requiring a code 3 response or not requiring an ALS unit, an advanced life support unit. Do you even need to send a BLS unit? And those are the subset of calls that then you're further kicking out to nurse navigation. So. And we did lay out how this was one piece of a broader step of a series of things to decompress the system in some materials that were shared with this committee maybe, I want to say 18 months ago or something like that, John, is that right? So we can share that with, I mean, those were previously shared reports, so you can see kind of how it fits in to the overall picture of those things. But we've always recognized that we actually need to be in a place where San Jose #1 is actually doing the basic mandatory triage for all of the calls, so we're not sending unnecessary ALS units out. Because what happens is if they can't do that process for those calls, automatically dispatch an ALS unit. And then the second piece is then to get nurse navigation signed up. I will say that the reception early on when we were launching the pilot from the city manager's office, which is distinct from, I just want to distinguish that from the fire department, which runs the actual 911 center. But from the city manager's office was very positive and wanting to try things out as soon as we had kind of worked out all the pieces. So I'm hopeful that we're getting to a place soon where we'll be able to re-engage the city on saying we now feel like we've fleshed out all the protocols and we've fleshed out those pieces to have them engage in that. But I have to say that if they're not successfully doing the basic triage on the front end, I don't see how they're going to implement the nurse navigation piece.
I guess I'm thinking, though, is 100, again, 100 calls in this time frame, is it enough to be able to, frankly, convince, the other communities to join? Do we need to be looking further? And given our, current pilot program, have we maximized everything we can?
I don't think we have. I
And
think that's where we're pursuing the additional iterations to try to maximize that. So we haven't.
But it sounds like the further iterations is to expand the scope. Well, I guess you would expand the criteria for.
Right.
Okay.
Yeah, so it's not just the geographic piece, it's the depth of the program, maybe is a way to think about it, yeah.
And then was there something about the nurses accompanying, or there's another part of the program, did you say, or did I mishear that?
Supervisor Koch, are you talking about the different levels or the different outcomes of that actual call?
Yes.
So, Dr. Darcy, if you want to take, but there's a couple of ways to come out of a call, right? So you can either have the call, which it goes to a 911 ambulance for the transport.
Right.
It can be deferred to a ride share. It can be deferred to a clinic for follow-up. It can be transported via BLS ambulance, or that patient could never even need to go to the hospital based upon the nurse navigation and the tools that they've provided to that patient.
Okay, so you're adding that extra option there.
And what we're trying to do in terms of the program as a whole is we've done the initial rollout with the 3 cities that are currently participating in it. The next step is the field referral protocol, right, which takes away the comm center having to do the full triage of the call.
Okay.
It allows the actual provider, once they get on scene, to assess that patient, determine that they meet criteria to go through the nurse navigation process, and then start to cancel resources on scene of that call that are no longer necessary.
So does that mean you're sending out nurse navigators to the field?
No, it's all done via phone line.
okay.
So they're incorporated, they're speaking to the nurse on the phone. That whole intake process takes about 90 seconds to triage the call, and then they're with that nurse navigator trying to determine the path that it goes from there.
Got it, great. So then you mentioned 3 cities, so what about the other cities within County Fire? So
I'm sorry, 3 jurisdictions, not 3 cities, my apologies.
So you are covering Cupertino, Saratoga, the ones, frankly, in my district, too?
Yeah.
Okay, great. All right, thank you.
Thanks. We talked a little bit earlier of the good news of the reduced ambulance patient offload time due to some of the procedural changes also in the ways that the ambulance patients are being offloaded to the emergency departments. Can you highlight some of these procedural changes?
Absolutely, Supervisor Lee. I think it's a it's a partnership between both the EMS providers and the hospital. So a lot of the ambulance patient offload delay really does sit with the hospital and sort of how they move patients in and out of the system, and being able to work with them to, one, reduce some of the volume, as James had mentioned, reducing that volume call and the stress of the system, so we have less calls going to the ED, as well as sort of where those patients go. So we've done a number of different things on the EMS side of the house. Some aspects were during COVID to protect patients. They stayed in the back of the ambulances while waiting for a bed, which is sort of create an out of sight, out of mind challenge. So we've worked with the hospitals to ensure that those patients can wait safely inside of the emergency department. Part of it has been triaging those patients from the back of the ambulance that are low acuity, can go straight to a waiting room versus waiting for an emergency department bed. And then really working with the hospital partners to figure out how do we help communicate better, how do we help provide focus, are there transport delays in terms of getting patients from one facility to the next to help decompress facilities. So it's been a great partnership on the hospital side. I can defer to my partners on the hospital side if they have additional comments on their procedural changes.
Supervisor, I
Yes.
think we have seen, looking at the improvement within the health system in partnership with EMS, we did see a reduction in the APOD time. I think VMC for April and May of this year, the APOD time was on average was 34 minutes and 41 minutes. I think we haven't seen that number for quite some time. So this is a welcome change. And I think we see the same for the other sister hospital in our health system as well. So we continue to work closely with EMS and internally just improve our workflow and efficiency.
Yeah, I mean, the thing that really caught my eye when I read this report, I'm just going to read it. In May, Valley Medical Center, 90th percentile APOD was 50 minutes less than it was in January. And we're talking about only 4 months' time. A 50 minutes decrease. So I thought that was amazing until I read the second part, which says O'Connor Hospital's 90th percentile was 70 minutes less than in January. So these are not, I mean, you reduce 5-10 minutes is what you usually see and say, oh, they're pretty good. This is absolutely incredible how big the number is. Or you could say the number before was really bad, and now that we're coming down, which is great. But I just want to say, so having regional medical center is a huge plus, clearly, number one. Second thing that's not really being captured is also, instead of having to go to VMC, O'Connor, by able to get to regional medical center, right off the bat, you are shaving potentially 15 to 20 minutes of the ambulance ride, right? So that, of course, is also potentially very much life-saving, as we all understand with the emergencies that we're dealing with. So in addition to these numbers, I would say that things have really improved significantly, and those are, like I said, the type of good news that we need these days. But I just want to say great job. And also with the improvement, you talk about how we could get the folks into ED and not necessarily move them to a bed. I think all these changes are certainly very helpful, and I just want to commend with the great work that's being done. And a lot of times we don't publicize the good work that we're doing, but these are the good news I think we really need to share more about. And as like you said, reducing the number of people that doesn't need to call ED, and that's of course is huge as well. So thank you very, very much for the great report, and I can't be happier than to read this. All right, with no further comments, yeah, I asked the public already. I don't think there's, yeah. So.
All right, happy to make a motion to approve the report.
And I'll go and second that. And I hope that the numbers keep going down, but really appreciate the good progress. All right, let's take a vote.
Just to confirm, I can't remember if we did, but no public commenters for item 10.
Correct.
And we'll take the vote
Vote,
for item
yeah.
10.
Correct. Thank you.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Thank you. Thanks. All right, moving to item 11, which is also a report from the EMS agency relating to the Emergency Medical Service System Assessment and Ambulance Services Request for Proposal, RFP. Go ahead, please.
We've submitted our report and happy to answer any questions you may have.
Okay, thank you. Vice Chair, any questions?
Thank you, Chair. Thank you for the report. I had a couple of questions. I'll be frank, I'm concerned about the data collection being done. June 30th is just a few days away. It looks like we have had not very good response from our partners. What are we doing in the next few days to get the information that we need?
Absolutely. Thank you for that, Supervisor Abacoga. So we are proactively working with our Fire Chiefs Association representative, who is our conduit to those folks. We have a meeting later today to discuss strategies to increase data collection and the speed. We also then have a meeting with EMS section chiefs on the fire side on Thursday, in which we'll again address any concerns or questions and proactively get that data. The sort of plan C, if you will, would be supplying that data that we have access to from the EMS agency, and then moving forward. So it's not a significant data in terms of call volume or other things. We have that data in the EMS agency. It's more germane to those departments themselves and how they operate. So plan C is to move forward with supplying the data ourselves.
Okay, so we have like the basic data, and you're just looking for any specific, unique circumstances within an agency, or?
Yeah, Supervisor Abacoga, it helps sort of frame for the consultant how this system works, how those agencies are built, how they integrate with each other. So by having that complete picture, it'll allow them to sort of more cohesively look at the entire system.
Okay.
And I would just say, I mean, one of the challenges I feel like that happens with these types of projects, not just specific to EMS, is, you know, we want to invite this on the front end so that what we don't get on the back end is somebody saying, well, that analysis isn't right because you didn't have my, you know, unique something or the other that was distinctive and specific facts. It's a challenge sometimes when people don't want to provide that up front, and then turn around and maybe make claims related to that on the back end. So I know that they're continuing to make that request here, but this is a space where that's happened before in prior assessments. So, you know, we will move forward with the assessment because we have to, and we need to move forward with the timeline.
Okay.
But that's just something that does sometimes happen.
Yes, I understand that it's a two-way street, but I just, having heard from many of our cities that they're very high interest in this issue, you know, I want to just make sure that we've reached out to them, and, you know, if we need to do personal outreach or help from our office, you know, we're happy to do that, but I just want to make sure we do our due diligence in trying to get that information from the different municipalities. One data point that I would like, and I think you should have it, is I know that there's been I don't know how to say, a call out to the different agencies for extra ambulances. And I would like to, I think our staff asked if for that number, that data, and just wanted to see the trends over time on that. Could you please provide that?
Absolutely. So you're looking for an off-agenda report on that data?
Yes,
Absolutely.
please. Thank you. And
And just to clarify, Supervisor Abacoga, looking for the number of times that a non-AMR ambulance has responded within the exclusive operating area?
yes, so my understanding is there aren't enough ambulances available. Those that call out to all the fire chiefs to see who has an ambulance that can get into service. So I'd like that.
Yeah, absolutely.
Data, thank you. So it sounds like then we're still on track to continue with the timeline that'll get us to the RFP process.
It's a narrow window, and a lot of things have to go right, but we are aggressively working that timeline to ensure that there is not a miss.
I will just remind the committee, and this is something, I don't even know what to say about this at this point, but we've been literally waiting years for the state to promulgate regulations around this process. And so what happened is the state had previous guidance, and there was litigation that said that guidance was an underground regulation. In other words, it had not gone through the appropriate notice and comment process for a formal regulation. So the court vacated that regulatory guidance and directed the state EMS agency to issue a formal regulation. It's now been a few years, a couple of years, and we still have not gotten that regulation. So it's been supposedly about to hit the street for years now. I just say that caveat because, of course, when it does show up, if it shows up in the middle of this process and
Yeah,
says something or
sure.
the other, it could throw a wrench in this. We've talked about it before, but I just, with new supervisor, I just want to mention it again. And it's been a huge source of frustration for every county agency up and down the state because it's just hanging out there like a cloud. And they keep saying it's about to come. I mean, if they would say they're not going to do one, that would be better, candidly, at this point, so that we would know we'd be proceeding without it. But I just want to name that because that's a huge X factor in this process.
And if I could add to CEO Williams' comments for Supervisor Abekoga, is the other thing is we can make the timeline for the things that are within our control, but to CEO Williams' point, this RFP has to go to the state EMS authority for approval. That could take 6 months, that could take 12 months, that could take less. So we can't control that, and that would have a significant impact on our ability to meet the timeline.
Well, and that was my concern, frankly, and that's why I understand the need or the desire to do the assessment, and I support it to some extent, but we have to figure out then where we're going to cut time to make this happen, because I don't know, and my question is, what's Plan B? Another extension, amendment to the current contract, which I don't think anybody really wants at this point, including I've heard from AMR. So that's just not an option, is what I'm trying to, and I understand that we don't have control of these other factors. So definitely I understand that, but I just want to, we don't have a lot of other options, frankly. So we need to make this happen. I just want to continue to emphasize that.
We have to keep moving it forward. I do think people, we obviously haven't had a full successful RFP since 2011, so it's been a long time. But I think people forget we actually did do an RFP in the middle of this process, in 2016, I think it was. Is that right? Yeah. In 2017. So we actually did an RFP process in 2017, and it was a failed process, which is why we then continued with extensions of the agreement. And so I just named that too because it's not as if we've done no procurement process at all since 2011. These processes have become exceedingly fraught across the state. Many of them have now resulted in litigation up and down the state. And I personally think we're broadly in a position where the state needs to revisit the structure of what's happening because there's probably almost a half dozen counties now that all their recent processes are all stuck in litigation. And that's, I think, a signal. And they've all done different iterations of things. So it's not because they all tried to do one particular thing. And to me, that's an indication that the state structure around this is not working.
Well, and maybe that's something that we bring up with our IGR team as a policy issue area for us to advocate for in the next session.
And I don't think the process worked for us in 2016, 17. So.
Yeah. Okay, great. Thank you. Thank you very much.
Yeah, this is certainly a very controversial issue here that we've been hearing for many years. Also want to talk about regarding the assessment and information gathering. Want to know if we are also gathering more information from community members and cities who are would like to give more input onto the EMS system assessment and what are the cities represented in the May 12 meeting and any additional outreach you think we might need to do?
Absolutely, Supervisor Lee. Thank you for that question. So the initial information gathering is purely EMS response data, and that's the initial phase. Phase 2 and 3 will be much more focused on community outreach, community leaders, hospital engagement. So we would welcome any suggestions you have in specific groups you think may be of value, but we generally will be looking at city leadership and major organizations within different jurisdictions.
Okay, no, thank you for that. I mean, I certainly appreciate the fact that you are trying to get this done even by end of this year. It's not going to be easy, obviously, for such a big issue. But I just want to say no, thanks for the hard work, and do keep us posted how we could help. All right, to get more inputs. And that's all I have. Let's see, open up to the public. Anybody like to speak?
No request to speak on item 11.
All right, thank you. Almost surprising that there's no public want to speak on this issue. All right, yeah, Vice Chair?
I'll make a motion to receive the report. Thank
And
you.
I'll go ahead and second that as well. All right, let's go take the vote.
Vice Chairperson Abekoga.
Aye.
Chairperson Lee.
Aye as well. Thank you very much.
Thank you.
Thank you. Item 12 is consideration of recommendation from the County of Santa Clara Health System relating to the current and emerging healthcare issues. Yes. Oh, yes. We have our public health officer here. Dr. Redmond, go ahead.
Thank you.
Hello.
So Sarah Redmond on behalf of the Public Health Department. I'll just share 3 very brief updates with the group. I think first, since the last time I was here with this body, the Public Health Department did identify and respond to the first case of measles in a Santa Clara County resident in many years. And I would just share that this was a very successful response. The Public Health Department did activate its Emergency Operations Center and work very closely, actually, not only with the individual themselves and their household, as well as healthcare facilities and workplaces, but we partnered closely with the County of Alameda, where this individual also was during the period they were contagious, and do a great benefit of the news media. We're able to notify the public that this individual had been in several public locations while contagious, so that the public was aware of the risk to themselves. And so at this point, I can say that we have completed the 3-week monitoring period after the last exposure, and that no additional cases were identified, which I think is a testament to the very high vaccination rates we have here in Santa Clara County, as well as the public and the healthcare system and the media and the public health department's rapid response to the event as soon as we were notified. Now, we continue to hear reports almost every day of new exposures, especially during international travel. So the advice for Santa Clara County residents continues to be, especially if you are traveling not even internationally, but to any parts of the country experiencing measles outbreaks, or even traveling through an international airport. We recommend people know their measles immunity status by talking to their doctor or checking their own vaccine records. Second is that this week's heat event happening in other parts of the county remind us that it's between the heat events that hit us here in Santa Clara County when there's really important work that needs to happen to protect people from dying during heat waves. Last year, we actually had 38 Santa Clara County residents die due to heat exposure in various heat events. And some of the most heartbreaking to me were individuals who actually had homes, sometimes even homes with air conditioning, that they either couldn't afford to fix when it was broken or couldn't afford to turn on. So the Public Health Department is engaged with community partners, promotores networks, to help educate people to understand their own risk of dying or having severe health concerns during a heat wave, and making sure that folks know it's especially these early heat waves early in the summer when our bodies are less able to respond to heat, and to know the signs of heat stroke, and to know how to protect themselves and when to seek cooling centers. And then finally, I'll just add that the Public Health Department and our public health pharmacy experts are really closely monitoring this week's meeting of the newly constituted ACIP. This is the group within the CDC that has been historically tasked with reviewing all of the scientific evidence and making recommendations upon a vote for in all of the vaccine recommendations that are then followed by health providers all over the country, and also decide what vaccines are covered, especially by public insurers. Now, because, as you may be aware, RFK Jr. did completely disband all of the sitting members of the ACIP several weeks ago and replace 8 of those positions just several weeks ago with new members. This will be the first meeting held of this newly constituted committee. There have been last-minute changes in that, as best we understand, the vote on a COVID vaccine recommendation has been removed from the agenda. So what I can share is at this point, these are all very bizarre complete upendings of what has been a decades-long process to ensure that vaccine recommendations that guide vaccine companies that produce the vaccines, guide healthcare providers, and guide insurance agencies in knowing what is going to be covered for their members, has been completely upended, and we just don't know what the new process will hold. I think the terms under which this process change is being touted is to increase transparency and trust in the vaccine scientific review process. And that is certainly also something I want to see. I want the public to feel that there is a robust scientific process that leads to the recommendations for what vaccines they should receive and the manufacture and monitoring of those. I'm extremely worried that that may not be what we have, and our team will have to see this week what the proceedings of the meeting mean for access to especially COVID vaccines here in Santa Clara County, especially affordable COVID vaccines. So I'll look forward to sharing more information with the board when I have that. And that's it for what I have for you today. I'm happy to take any questions.
Yes, thank you, Dr. Redmond. Actually, let me just start with that follow-up on the COVID vaccine issue. Not having a vote on the COVID vaccine, does it mean that the federal government will no longer be paying for any COVID vaccines moving forward? So what they're looking at, number one. Number two is, how is the access to the COVID vaccine would be for us moving forward this fall?
I think we just don't know the answer to either of those questions right now. So not only is the vote, we don't know whether there will be a vote, but it will be delayed. We don't know whether the new CDC director will decide to approve a recommendation absent a vote and make it based on their own personal knowledge or other decision-making factors. And then all of that leads to what the CDC will have officially recommended once this process unfolds to the extent it's going to. Then there is still the question of what the FDA will approve or authorize. And that adds an additional layer of what is even allowable, accessible. And then all of this has overlapping effects on what vaccine manufacturers choose to create. If they are not sure whether their vaccines will be approved or authorized, you can imagine they may have different planning assumptions about what they manufacture and how they distribute it. So we could see any range of outcome right now, from significantly decreased even access to legally available COVID vaccines that are updated, even at cost to an individual or their county. Or we could see, very similar to last year, full recommended coverage of fully available COVID vaccines and almost anything in between. And I just don't know what we're going to see, but I'm certainly monitoring closely and concerned in making sure that rigorous scientific evidence is taken into account with the recommendations that apply to Santa Clara County residents, and that public health is prepared to take steps and work with our partners in insurance agencies to make sure that we have not only access to vaccines, but affordable access.
Okay. You mentioned the measles update, which has been good news for us. Not good news that we have a case, but good news to see that that's the only case, and that the subsequent work that we've been able to do and all the public service announcement and whatnot, folks are able to limit that to only one individual case. Is there any risk that the current regime of the MMR, the mumps, measles, and rubella vaccine that's been used for decades, do you see that this potentially could be changed due to the new ACIP?
Again, I just don't know the answer yet. Now, my best understanding is there's not an agendized discussion right now for the MMR recommendations to be reconsidered, but we have seen, a bypassing of the usual procedures for what is typically an ACIP agendized public meeting, followed by a public vote, followed by a public approval by CDC, and then subsequent following of those recommendations. Because we have seen leadership at the federal level make policy announcements and decisions absent that or in advance of that scientific process over the last several weeks, I don't know whether the usual processes will be followed. So I don't know whether it is reassuring that we have not seen an agendized discussion to reconsider those processes. So all to say, I don't know. What I can say here is that we are fortunate to have very high vaccination rates that provide an incredibly high level of protection to our community, and that's why we've seen such successful control of measles here locally.
Right, and so the takeaway is for folks, check your shot records, especially if you're going to travel, to make sure that your shots are up to date, especially the MMR
That's
for the
exactly
measles.
right.
That's the word. Having retired from the Navy after 28 years, one thing we learned in the Navy is if they don't find your shot, your record, you get another shot. So I have plenty of those multiple shots, I'm sure. I even get a anthrax vaccine before I went to Iraq. So I have all kinds of vaccines in my body, so.
Glad to
But anyways, let's get a word out to folks. Go get your vax record checks, please. Thank you. All right, yes, Vice Chair, go ahead.
Thank you. I was going back to the COVID vaccine or vaccinations. What is? I know we don't have a lot of say, but I'm thinking of like advocacy groups and the doctor, even maybe. Well, the pharmaceutical companies, do you see this, and I'm sorry that Bert left, but some kind of effort to, advocate for the continuance of vaccinations and what we've had, or?
So I'm seeing multiple levels of advocacy. I think what's difficult is we don't know yet at which level we need to advocate. If there are limitations with what is actually approved or authorized by the FDA, that requires a different level of response than if they are authorized and approved, but folks can't afford them because they're no longer recommended, or because or folks don't have access to good scientific information to understand what would be recommended. One example of the kind of work that is happening is there's a group out of University of Minnesota, a longstanding set of experts in public health who have convened what they're calling the Vaccine Integrity Project, that are widely recognized as deeply knowledgeable national experts doing their own rigorous scientific review, so that if we have concern out of what comes out of the new ACIP, we have somewhere to look for additional expert review. But on top of that, there will be questions of affordability if there is access but no coverage, and that's another question we're preparing to understand how we might respond locally.
Well, right. Well, appreciate.
I would add two things on that latter piece. One is you may be aware that there's some legal attack on the structure around in the Affordable Care Act around preventative care coverage, which includes coverage for free in all health plans of vaccinations. And so that's still meandering its way through the legal process. But that's one concern. And then, of course, there's the underlying concern that they may, at a federal level, just say it's not something that has to be covered, which, then we'll leave it back to a situation that we had before where it becomes a plan-by-plan issue. That's, of course, all assuming that they don't take the much more aggressive step that Dr. Rudman was alluding to of, actually declining to authorize the vaccination altogether, which would functionally make it so that nobody can get it. I do think that's a more extreme action, and we haven't seen indication of that happening, but that would be a really serious concern and impact. And that's one of the crazy things that could come out of this reconstituted committee that is using pseudoscience.
Thank you. I had a different topic I wanted to bring up. I know we've talked in our meetings about Asian American Pacific Islander disaggregated health data, and I recently had a chance to read the December 2024 report on the evaluation of the API, Asian Pacific Islander Community Health Worker Program in Santa Clara County, and I thought it was very helpful, really enlightening information. I guess this came out of the Asian Community Health Assessment in 2018. The Community Health Worker Program was an offshoot of that, and that's what this report was about. Clearly, I think there's good work that's happened with the program, And would like to, Chair just left, but I would like to request that we agendize a review of the information that was provided in that report here at HHC at our August meeting. And then I understand the program itself will end as of June 30th in a few days. And so I would like to have that opportunity at our next meeting to better understand the disaggregated data and then our plans for the future of the community health worker program. So hopefully I can make that request to the chair. Yep. Great.
Absolutely.
Great. Thank you very much.
Thank you.
Yeah, just for the audience, even though we might step off the dais, this is also being broadcast in the back, so we absolutely heard everything that was being said in the front as well, including a TV that I've asked to put in so that we can actually see what's going on. So we're not missing a beat. Thank you. All right, let's see. We have next, I believe, is our Chief Medical Officer, Dr. Fong. Anything else to add? Okay. All right.
Report.
Good. Okay. All right. Thank you. Next, I believe we have our Behavioral Health Service Department. Darren?
Thank
Tan.
you, Chairperson Lee, Vice Chair Abikoba. Darren Tan, Deputy Director, Behavioral Health, and I have 3 brief updates for you today. This summer, the state is rolling out its Center for Excellence for the BH Connect Evidence-Based Practices, known as EBPs. The department intends to implement all the EBPs required under this initiative in order to claim Medi-Cal reimbursement for short-term stays in facilities that were previously excluded from federal Medicaid reimbursement. BHSD's network already contains many of the EBPs included in BH Connect, so we believe we are well positioned to maximize the funding available under it. The department will work with its network providers on the BH Connect EBPs and is convening bi-monthly town hall meetings to provide education and updates beginning in July. Providers were also surveyed for their interest in participating in the BH Connect EBPs, and many expressed interest in implementing one or more in their agencies. Information on further details of BH Connect has been delayed in part due to the change in federal administration, and we would be happy to provide a more in-depth overview at a future committee or board meeting. The second updates in regards to PERT. BHSD met with the Public Safety Communications Managers Association in early June to inform them of the PERT closure that has been deferred to December. We will return to their August meeting to provide more information on the 911 to 988 transfer process and how to direct access to mobile crisis response team clinicians to provide consultations for our law enforcement agencies, our LEAs. The department will also meet with all our local LEAs in August and September to provide information on how they can have direct access to mobile crisis teams using a backline exclusive only to them. We will also discuss how we can coordinate co-response as well as provide clinical consultation for crisis calls. And the last update I have is very brief on Behavioral Health Services Act. Community engagement efforts for BHSA implementation will be occurring in July into the middle of August, consisting of a series of town halls and listening sessions. We've been in contact with our board offices for potential partnership opportunities to facilitate some of these discussions. And as referenced at the June 17th board meeting, further details of the implementation will be presented to the full board in December. And that's all the updates I have for you. Happy to answer any questions you may have.
Thank you, Darren. Yes, Vice Chair.
Thank you. Thank you for the information, especially on the PERT program. As you know, that's of high interest to me. And if it's possible for our staff to be involved with your meetings with the LEAs in District 5, would appreciate that. Thank you.
Great.
Okay. All right. Next, we have Laura Rosas, our Valley Health Plan CEO.
Good morning, Chair Lee and Vice Chair Abikoga. Happy to be here this morning. You do have our report. The only thing I would add is that we are carefully watching what's happening with Covered California and the marketplace as well in Washington, D.C. The focus has really been on Medi-Cal, but there are significant changes that will likely happen. First of all, even without any congressional action, there will be an end to the subsidies that have made Covered California really affordable. That those will go away at the end of the year. So we're going to see a reduction likely in enrollment because of that. And then there's a number of other changes that likely Congress will take on the marketplace plan. So we'll have more information in our next report in probably the August timeframe on those potential changes.
Great.
Happy
Thank
to
you.
answer any other questions.
All right. I don't see any questions here. Going down the pipe, Dr. Salmon, welcome.
Good morning, Chairperson Lee, Vice Chair Abe Koga. First of all, thank you for inviting the Enterprise Medical staff to join the dais today. We appreciate your support. The Enterprise Medical staff is very pleased to now include Regional Medical Center as one of our service locations. As it was previously reported, the census at RMC has grown rapidly, perhaps faster than we anticipated, which again really highlights the importance of this hospital to our Santa Clara County community. That being said, one of the main priorities of our Enterprise Medical staff is to maintain as well as expand services to the residents of Santa Clara County, particularly the most vulnerable communities. Thus, we advocate for increased staffing for our hospitals and specialty services, as well as increased collaboration with our community physicians and contracted physicians so that we can provide a broad spectrum of services and maintain capacity as our needs continue to grow. So we're working very closely with Santa Clara Valley Healthcare Administration to develop relationships with our community physicians and contractors, in addition to partnering on recruitment for employed physicians. So while we've been fortunate to bring many new physicians to our medical staff, we'd like to note that nationally we're facing a shortage of physicians, particularly in primary care, which is an ongoing challenge that we'll need to address. So this shortage, combined with the high cost of living of the Bay Area, makes for a very competitive market for physicians, not only for employed, but for obtaining contracts with groups and community physicians. So we will need to maintain a competitive work environment while also being sensitive to the fiscal concerns facing the county. In addition, we're continuing to integrate the culture, the policies and procedures of our medical staff across our now 4 hospital sites and ambulatory locations. So to this end, you've been receiving periodically our enterprise-wide privileging documents as well as enterprise-wide policies, which illustrate how we are standardizing our practices across the health system in an effort to ensure and maintain, the highest standards of care in our health system. And I'd like to highlight that the diversity of our medical staff, with having community physicians, contractors, and employed physicians, it has really brought a variety of experiences and backgrounds that has allowed us to expand our best practices and innovate throughout our health system. And finally, physician wellness continues to be an area of focus as we're also facing a national wave of burnout across healthcare systems. So we're partnering very closely with administration to continuously assess the wellness of our medical staff and identify opportunities to improve efficiency, quality, and safety. We've also partnered with administration to improve access to mental health care resources for our medical staff, not only for those who are employed, but for those who may be community physicians or contractors who provide care within our system. So I think it will be very important that we continue to maintain these wellness efforts, even in light of the ongoing budget concerns as we face both federal and state cuts in funding, as wellness efforts, paradoxically actually are beneficial to the budget as they improve efficiency, reduce provider turnover, and also work towards improving the quality of care delivered. Finally, we would like to again thank the board for their ongoing support of our medical staff and our health system as we continue to grow and care for the Santa Clara County community. I'm happy to answer any questions you may have.
Thank you very much, Dr. Salmon. I don't see any lights. Okay, let's see. Do we have anyone in the public who would like to speak on this?
No request to speak on item 12.
All right, good. I'll go ahead and close the public hearing on that as well. Let's see. We have a motion to receive the report.
Motion to receive the reports.
Now I'm going to second that. Let's take a vote.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
All right, this brings us to the end of our meeting today, and we'll now adjourn. That thank you to everybody attending today's meeting. Next HXC meeting is scheduled for Wednesday, August 20th at 2 p.m. at the Board of Supervisors chambers right here. Same place, same channel. Thank you very much, everybody, and hopefully everybody have a good break for July. Thank you very much, and stay cool. All right, thank you again. Thank you. Meeting adjourned.